Wonderful to see you. Welcome to Table Talk, a reimagined series created by and for underrepresented communities. My name is Andy Engel. I am senior programmer at Reimagine. For anyone who needs a visual description, I'm a white cisgender male. I've got glasses, I've got an orange background behind me, and I've got grayish hair. And COVID is making it even more gray. This Table Talk is co-hosted with PCHS, Punjabi Community Health Services, which serves the Greater Toronto Area. Their mission is to improve the well-being of diverse individuals, families, and communities using an anti-racism and anti-oppression framework. Representing PCHS tonight is Ansjot Kapoor. And Ansjot, I'm really delighted that you're here with us, and I would love for you to share a few words about PCHS.
For sure, Andy. Thank you so much for giving PCHS this platform to co-host and introduce ourselves at this event today. My name is Ansjot Kapoor, and I am the current manager of health at Punjabi Community Health Services, and today representing PCHS. Thank you for the lovely introduction. Today's topic, palliative care in the South Asian population, is very close to our heart at PCHS. Over the past 30 years, PCHS has been providing services to our community, including our geriatric program, which is very special to us. That includes our integrated seniors team. Our scope in our geriatrics program includes supportive counseling, caregiver support workshops. We also provide educational sessions and just have that connection with our seniors in the South Asian population, where we're able to provide them the care that they really deserve. And I believe today's topic will hit home. In culturally speaking, our palliative care conversations in the South Asian community are very much needed. So I would really like to thank Dr. Sethi and Dr. Dasani here today that have taken this opportunity and time to talk to us about this important topic. Thank you.
Thank you, Ansjot, and thank you again, PCHS. So here's the central question of Reimagine's Table Talk series. What does it mean to live and die well, specifically among groups that have been historically marginalized, who experience obstacles to healthcare and death care? Our vision at Reimagine for Table Talk is that it becomes a regular booster shot of knowledge, empathy, cultural humility, and community. While these conversations are by and for underrepresented communities, everyone is invited to these spaces to witness, listen, and learn. And you can view recordings of Table Talks to date at letsreimagine.org/tabletalk. And I'll be putting links in the chat later. And you should know that for anyone who registered for this particular Table Talk, you'll be receiving a recording of this, hopefully by the end of the week. And I want you to save the date for our next Table Talk on June 15th. It's called Climate Grief and Eco-Anxiety in Puerto Rico. We have 3 LGBTQ+ leaders from Puerto Rico speaking firsthand about the effects of pre-traumatic stress in a world of natural disaster, climate change, and inequity. So tonight's Table Talk will be a 40-minute discussion that centers South Asian perspectives on palliative care, and it will be followed by 15 to 20 minutes of Q&A. So I hope you'll all prepare questions for this, what promises to be a very fascinating discussion. And for those who wish, you can click on the CC icon at the bottom of your screen to get a live transcript of what's being said. And throughout this conversation, if you have any questions about technology, you can send me a message in the chat and I'll try to help you. So the majority of us are zooming in from the United States and Canada, also known as Turtle Island by First Nations and Native Americans and their allies. I am in Lenapehoking, also known as New York City. please let us know in the chat where you're located. And if you want to know the Indigenous land where you're located, you can check it out at this fantastic Canadian website, native-land.ca. So now, I'm going to briefly introduce our speakers. I've had the pleasure of collaborating with both of them on previous Reimagine events. Naheed Dosani is a palliative care physician and health justice advocate. He is dedicated to advancing equitable access to healthcare for people experiencing homelessness and marginalization. These efforts include founding Palliative Education and Care for the Homeless, otherwise known as PEACH, and serving as medical director for a regional COVID-19 isolation housing program in the Toronto area, and I believe that is PCHS. His research also includes interventions to facilitate greater appreciation and upstreaming palliative care in South Asian populations. Aditi Sethi is a hospice and palliative care physician, an end-of-life doula, and executive director of the Center for Conscious Living and Dying. She's also a gifted musician specializing in Indian devotional music and Americana. She performs as part of the Appaloosians with her husband, Jay Brown, a musician and music therapist. And she will be featured in the forthcoming documentary film, The Last Ecstatic Days, which is produced by our colleague at Reimagine, Dr. Jessica Zitter. Aditi lives in Black Mountain, North Carolina. And now, we can't have this table talk with the fabulous musician Aditi Sethi without hearing some beautiful music. So Aditi, can you tell us about a song that you'll play for us?
Oh, thank you for that introduction, Andy. And welcome everyone. It's an honor to be here. I'll share with you a Hindi song that I sung for my auntie, one of my aunties who died of lung cancer probably 20 years ago. And I sang it at her funeral. And it's a song that basically asks the question, you know, when you leave this world, where do you go? And how can we find you? You leave no trace behind. So it's a song of remembrance and love and yearning. And I'm playing a harmonium. It's a little too heavy to lift up, but.
Thank you, Aditi. Now I'm going to spotlight you and our other very special guest, Naheed Dosani. Now, what I like to do on these table talks is ask each of you to define the topic that we're exploring. And we've titled this one, South Asian perspectives on palliative care. And I know often in certain countries, palliative care and hospice care are sort of lumped together. In places like the US, there's a newer trend to try to separate them out. So maybe I'll start with Nahid. You can tell us how, maybe perhaps the textbook definition of palliative care, and maybe a more personal definition of what palliative care is, and then we'll go to Aditi for hospice care.
That's great. Thank you so much, Andy. Such a pleasure to be with you all tonight, and with my incredible colleague Aditi. And thank you, Ansat, for that incredible welcome. I'm coming to you guys from the city of Toronto, which is the traditional territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, otherwise known as Treaty 13. And yeah, you know, as if it wasn't already confusing enough, there are different ways to define hospice palliative care or palliative care. And I think one way that, you know, I really talk to people about palliative care is that palliative care is an approach to care which emphasizes quality of life for people with serious illnesses at any stage, at any phase of illness. It's not necessarily a place, it can be, but it's more of a philosophy of care. It aims to provide holistic care. It aims to care for people's bodies, their physical symptoms, like pain, for example, but it also cares about their emotions, their psychological pain, their suffering, and also their spiritual suffering that might occur. In many ways, I personally describe it to go further to talk about it's an approach to care that meets people where they're at a time when it's very difficult to find care, or so often health care, to care for someone who's dealing with those kinds of circumstances. And so, yeah, there's a few different ways to define it. Those are some of my approaches. Aditi?
Yeah, so hospice, the way I like to talk about it is that it's a philosophy of care, similar to palliative care, and then it's a system in place to deliver that care. And so as a philosophy, the philosophy is that when someone has a prognosis, they're told that they probably have 6 months or less to live, knowing that that is not always easy to predict, that the goal would be to ensure that they have the most quality of life for whatever time they have left. So that's the philosophy. And then the system in place is this interdisciplinary team approach that goes into the home, a nursing home, assisted living facility, wherever that individual calls residence, or if you're lucky to have an inpatient facility or a hospice house, or the hospital sometimes. So, and then also in terms of people get confused, and in our country we use the terms interchangeably, hospice, palliative care, and the way I describe it is that all of this care that we're providing is palliative in nature, meaning to alleviate suffering, and it's comfort care and holistic care. But I like to separate it into hospice palliative care and non-hospice palliative care. Non-hospice palliative care meaning you can access it at any time in your illness, during your illness. So
I think what further confuses the matter is that we often are living in death-phobic cultures and death-phobic societies. As a Canadian, South Asian, you know, for me growing up, there was a lot of discussion about, you know, the hope that I would one day be a doctor, maybe by my parents, but not so much a palliative care doctor, because I think for my parents that might have been a scary concept, because, you know, in some cultures, and I'll speak from my experience as a South Asian, that there was often an avoidance of the discussion of what it means to be ill, on the precipice of dealing with a serious illness and perhaps even death. And so as I went through my medical training and as I went through my healthcare training during medical school, I didn't really consider palliative care to be an area of expertise or a specialty that I would necessarily participate in. And then it basically turned out that while I was in residency, I was providing healthcare in a shelter for men experiencing homelessness. And I ended up providing palliative care for an unhoused man who presented with a widespread head and neck cancer, and he had a mental health history, and he was on the streets for a very long time. And due to stigma, he actually ended up getting lost in the system. His cancer grew, he started to experience pain, and he went to multiple hospitals and ERs to seek adequate pain management and palliative care, and he couldn't get access to palliative care. and that really was horrible for him. So he presented in our shelter, in my care actually, while I was a resident training, and I worked really hard to build trust and build a relationship with him. And I got to the shelter the next day, and I couldn't find him anywhere. And I had learned that he had actually died the night before. He had basically overnight, he had overdosed on a combination of alcohol and street drugs. And because of a lack of access to palliative care, he turned to the best pain relief that he knew. It's a very unique and very specific way to be introduced to the concept of palliative care, but it was in my face at the time that there were huge inequities in access to healthcare, but particularly huge inequities in access to palliative care. As the years, this actually led me to pursue further training and do a palliative medicine residency at the University of Toronto, become a palliative care physician, and then start, Canada's first mobile palliative care program, caring for people experiencing homelessness, called the PEACH program, Palliative Education and Care for the Homeless. And it started out the back of my Honda Civic, a half day a week, and it's kind of grown into this massive program now that cares for 120, 130 clients on caseload. And we have, a team of nurses and social care workers and palliative care physicians and a psychiatrist, and it's been replicated in cities across Canada, and even around the world. But it really was the beginning of my justice exploration around palliative care, which actually brings me to this talk with you, to realize it's, people experiencing homelessness is one example of palliative care inequity we see in our communities. But, race and, systemic racism, and diversity and culture play a huge role in who's accessing and not accessing palliative care. And there's no doubt in our South Asian community and communities, the diaspora, where we are around the world, we are not talking about the issues of palliative care. We are not talking about aging. We are not talking about death and dying. And unfortunately, that means that people aren't getting the care and the resources they necessarily need. So, that's a little bit of my story. Aditi, you've worked very hard on this vision for the Center for Conscious Living and Dying. Can you tell us a bit about that and what that is, first of all, and how you got there?
Yeah. Yeah, I could listen to you talk about your story forever, but I'll dive in. So similarly, the immigrant culture, my community coming, to the States, there was very much this ideal of the American dream, and through whether it's any kind of secure job, engineering, physician, medical or other. And when I was 17, I heard of hospice for the first time at a college fair, and I was surprised. I was shocked that I'd never heard of hospice before. And I'd grown up in a community of physicians, and I'd been to India and seen death so integrated into life. And then coming back to the States, it was always surprising how siloed everything was, and how individualistic we were, and how hush-hush we were about illness and death. And I started volunteering for hospice when I was 17. And so I'm 41 now, so that's almost 20 plus years ago. And then that experience, I ended up studying religious studies in undergrad and medical humanities. So I was always kind of drawn to the bigger questions of why, what are we doing here? And I also love the science of medicine. So bringing those two together in hospice seemed like a good fit. And as a hospice volunteer, I got to really be present with people who were dying and experience the whole spectrum of suffering that I witnessed. And throughout so I'm going to jump around here, but in one of my Eastern religion classes, my professor talked about Varanasi, one of the oldest towns in India, maybe the oldest, where these funeral pyres, these crematory pyres, are just 24/7 are burning, and with dead bodies, and there's so much ritual and ceremony around it, and then the cremated remains are thrown in the Ganges, where people are bathing and children are swimming, and it's just so part of the cycle of life, and it's so integrated. And I was still fascinated by the difference with what I'd seen with death in America, and to this day am. So ritual, kind of the approach to death that allows families and children to really be a part of that process, has always been fascinating to me. So fast forward, I ended up going to medical school, did family medicine training, and I was just sort of in this observation state for the last 20 years of really observing how are we talking about death, and how are we preparing people for death, and how are we preparing ourselves to take care of the dying, and confronting our own fears of mortality, right? And so I watched, and then that led me to do a hospice palliative care fellowship, which is, I don't know if you guys have that, you probably do, extra year of training or two. And then I worked in an inpatient hospice house, 26 bed for 10 years. And that's in Asheville, North Carolina, home of the Cherokee. And I, again, sort of observed, many people still after 20 years weren't doing their advanced directives, weren't planning for death, weren't resolving issues with estranged family members, weren't thinking about their legacy, weren't talking about death. There's a writer and grief worker, David Kessler, who said in a talk recently that we prepare more for a weekend getaway than we do our own death. And I thought, wow, let's sit with that for a minute. So that combined with going into nursing homes with my husband, who's a music therapist, and seeing how we care for the elders, and a friend called it warehousing elders, that really, I couldn't just do my work and not address some of those things, or at least try. And so the vision for the Center for Conscious Living and Dying is really to support from a community-based perspective, not a medical model of dying, because I saw that wasn't going to do it alone. That really we can reclaim death as a sacred part of life and teach people how to be with dying again, like we used to be back in, not too long ago, actually, and really support caregivers. And yeah, so there's a lot more to center, but that's the gist. So.
Great. So just sort of moving on, Aditi, what are some of the misconceptions and fears that you've seen surrounding palliative care when it's being accessed by people, or should be accessed by people?
Well, the American Academy of Hospice Palliative Medicine recently had a conference this year, and one of the talks was about palliative care, and it was people from Stanford that said that 70% of Americans don't even know what palliative care is. And so education, if you don't know what it is, you can't really speak to it and understand it. So you might have a lot of fears around it. And this idea that palliative care and hospice are the same. So, nobody wants to quote unquote give up and let the illness take over. And nobody really knows, many people, I shouldn't say nobody, I should clarify. People that I've encountered feel that if you talk about palliative care, then you're inviting death, or death's going to come sooner. And so I think that's a big thing. And then not understanding that it's a consultative service that you can access just like you would a neurologist or a brain doctor or a kidney doctor. You would ask for a consult, or your providers would access that. And that can be complementary with your curative treatments. I think that's part of it, just education, really. And then, of course, access, when we talk about other communities that can't get rides to the outpatient clinics or those sorts of things. So what would you say? Do you have a...
Yeah, in some of my other work with one of the other hats I wear, I worked for, several years in a South Asian community, Brampton, Ontario, Peel, providing care for, a significant population of South Asians in our community. And some of the things that, really resonated, that you already mentioned, was the fact that a lot of people were not ready to have the conversation, that the P word in really inspired fear actually in people. And actually, I'm just going to share that, this led me to do some research, and I just put the link in the chat. I realized that there had actually never been a study, talking to people who were South Asian who were in need of palliative care about their perceptions of palliative care. I felt that was step 0 before even step 1. And so we did the study for basically 2 years, talking to South Asians who were in need of palliative care at our institution, our hospital. And, it was really an eye-opening experience. I mean, we even designed the framework of the study to be patient-directed, but a lot of the time, family members, South Asian family members, wouldn't even let us talk to family. They would shield their loved ones and be protective. And I think it was very apparent, even in the study methodology when we were doing it, that family members play a huge role, and the family unit is often very large, and multiple people play a role, and there's a strong desire to keep people at home for as long as possible. And that really came out in the study. But I think the TLDR, the basic headline of the study, was that when we talked to South Asians who were about to receive palliative care, but what they thought of palliative care, they were very much fearful of the term. Like they wanted to run away from it. Basically, this was not for them. This was something that was a very bad thing, and they wanted to avoid it. But when you asked them what they needed was an approach to healthcare and care that alleviated suffering. Well, guess what? That's what palliative care is, right? And so it showed us that a lot of the times the way we present palliative care in our healthcare systems is a one-size-fits-all approach, which is probably like a Eurocentric kind of approach that does not kind of really meet the needs of culturally diverse communities. And there's a lot of literature to show, how we're introducing palliative care to Black people or Asians, or Hispanic and Latino populations as well, that we are kind of missing the boat. And so we have to customize our approach to explaining things, just like we customize our approach to care. I mean, it's wild that we had to do all this research to prove this. It's really not rocket science, but it kind of proves some really important points. And so I thought I'd bring up the study just to say that it kind of answers some of the questions that we're talking about here. And I hope it's helpful in framing, and happy to chat further about that. But, I also think, family unit piece is really important. Aditi, I want to zone in on, your experiences in working with immigrant families. What are some examples that of experiences you've had? I'm thinking about, of conflict, that sometimes things have gone awry maybe, but what about cooperation where things have gone kind of well? Like when you think of that continuum, what do you think of?
Wow, that's a good question. I just want to say that I read your article before I even met you. So it was really, I'm so grateful for it. It's good to educate ourselves as well on all the diverse perspectives on death and illness. So thank you. And I grew up in Augusta, Georgia. Born in India, moved to Georgia. Very little diversity there growing up. I think we were one of 12 families. Now there's probably 1,000. And then I now live in Asheville, North Carolina, still in the South, but not a very diverse population. And so I can speak mainly from my personal experience with death, and then maybe a few cases that I've seen that are similar actually for me across all the different cultures, that there were many similarities. And then I think there's confusion. There's not confusion, but there's variation based on how modernized or how westernized families have become. And so that's what I can speak to. But I don't know if you want to speak to your experience before I jump into the personal, because professionally, you're very diverse.
Yeah, I think professionally, I think when there are issues with the acceptance of palliative care, it's because people are viewing our South Asian families are viewing palliative care as if something is being taken away. So, they're introducing palliative care. That means no more chemo. That means no more dialysis. That means no more XYZ. And that's actually not the situation, although that's how it's being perceived, right? In fact, what I try to really train, particularly my South Asian families, to see it as is actually a set of tools, equipment, like sometimes literal equipment in the home, but I mean a suite of tools to actually support you and your family through a journey, and an extra layer of support, everything from home and community care to having a nurse come to your home, to having health professionals assess your pain and symptom management, to spiritual care, to counseling, to anything and everything in between. And so where I've seen conflict happen is because maybe we didn't do the best job that we could have in introducing it as a suite of tools that add rather than take away. And I know that's a fairly simple concept, but that's where I feel like the root of a lot of issues lie in many of the much of the discourse I've kind of had. Growing up, as a Canadian of South Asian descent, certainly, I would say that there is a sense of death phobia that exists in our culture and culturally, and talking about death and dying. Maybe after death, from a religious perspective, there's certainly a lot of talk about that. Went to many funerals, there were many ceremonies. That was very part and parcel. But the part where people were dying didn't get talked about a lot, got avoided a lot. And what that unfortunately means is that advanced care planning is not part and parcel of a lot of the conversations, a lot of the journeys that many people people are going through. And with aging demographics, that's unfortunate because, we know that advanced care planning is so important to, for people to plan their wishes when they get sick, what they would want if they ended up in hospital. And while we cannot predict an infinite number of things that someone would go through, advanced care planning is, again, a tool in your toolbox to really plan for the future, plan for the inevitable. And so I think that was like really something that really stuck out. It's interesting now that I work in palliative care, doing events like this, it's like going full circle. It's an opportunity to give back culturally and enrich an already very rich culture, to be, less death phobic. I think that's the theme I'm going to really focus on. Aditi, how about you?
Yeah, no. So I had some pretty potent experiences with people I loved in our Indian community that died. And what I've found, and actually the Lancet article, there's this 40-page commission paper. If you haven't checked it out, you can look it up. And it's the Lancet's one of the oldest journals in the world, and they came out with a 40-page commission paper called "The Value of Death: Bringing Death Back to Life," and it's all about kind of realizing that death is a natural phenomenon. It's not a medical event. It's a social, spiritual, relational experience. And so they even talked about how in India, there's so much faith in technology now and so much faith in Western medicine, to the point where death has changed even in the last 20 years in our Indian culture, abroad. And so I would say that faith and trust in technology and the medical model, the biomedical model, has really informed how we approach death. So the three people I love dearly, in our culture, everybody's auntie and uncle. They're dear friends and family friends. But one of them specifically came to me knowing I was a med student. He knew I was interested in hospice at the time. And he told me, he said, I am so tired of chemo, so tired of fighting, quote unquote, that battle metaphor. And yet I can't stop. I can't stop doing this because Auntie won't allow it. She just can't accept the fact that I could be dying. And so they just didn't even talk about it. And so the deaths, that's one example of the death the dying process that I experienced. And he ended up dying in the ICU, fighting for life, at all costs. And then another uncle that I really loved, I just one day heard he died. And I couldn't believe it. I didn't know he was ill. There's a hush-hush, very quiet and secretive. And I don't judge it. I just wonder if there was less death phobia and more normalization of death in our communities, if it would have been different. That's more my curiosity. It's not none of these are judgments. It's just, this is what is that impacted me and my path. And so it turned out he had lung cancer. He didn't want anybody to know. He ended up living his final days in the hospital with his isolated unit, is my understanding. And I still don't really know what happened because nobody talks about it. There's no good time to talk about death, right? That's kind of, my friend Greg talks about, when do you talk about death? When do you plan for death? Is it when you're healthy sitting around the Thanksgiving table or dinner table? No, my brothers would say, why are you bringing up this depressing topic? Or is it when you get diagnosed? Then no, you can't talk about death because you want to fight and you want to cure, and let's not go there. And then you don't talk about it. Some people don't talk about it even in the days prior because you don't want to give up hope. So it's one of those things, the death phobia, like the just this removal from like death as a natural phenomenon, I think is a big part of the phobia. We don't acknowledge it as natural.
And one of the things that, to add to that I always struggled with was there was always this like feeling that, South Asian families have been, in my experience, some of the most determined families to make sure that their loved ones stay at home, age at home, deal with their illnesses at home, and yet are often turning away palliative approaches to care and extra support. And how I would try to bridge that is like, man, you want to keep your mom at home, you want to keep your dad at home. Well, this palliative care thing is going to be the tool to make that possible, right? And that link has been, seeing it as like a practical tool to achieve, cultural values and ideals. I think that has allowed us to be able to deal with a lot of difficult situations too. So that comes up quite a bit.
That's great. Stanford, the same folks that spoke at the American Academy Conference, their approach to some of these I don't say dilemmas or, disparities, is that really using the medical model and collaborating with communities that are actually having these conversations in creative ways. So you're right. If they only knew what palliative care was and how it would enhance the care of their loved ones, then of course it's a no-brainer, right? And that's true for all populations, I think. We
You know, so this leads to a conversation about, barriers to access to palliative care. And I think a lot about this. I know you do too, Aditi. So when you think about what are the strategies that exist to help us overcome barriers to hospice palliative care in North America, particularly for South Asians, particularly for racialized people, and people who are underrepresented, in this setting? Like, how do we address these barriers?
Yeah, to me, education, awareness, and maybe the creative approaches to that. Like, how do we educate individuals and their communities? How do we go to them? And some of that will come from partnering with nonprofits, and the medical system can only do so much. We're busy in other ways. So collaborating, kind of joining forces with community members, getting creative with how we provide care as well. We have a caregiving crisis in this country, and as the baby boomers age, there's evidence that it's going to be even more challenging to find support in the home. Many people want to die at home, but that's not always possible. And like with our families, and children are all over the world now, and so for them to take time away from home, all those factors, kind of addressing the social, spiritual, emotional, physical, the whole approach to how we talk about these conversations. I think it's
Yeah. I think those are some important points. I would also just basically say that we probably have to start at a place where we recognize that the systems that we've designed do not adequately meet the needs of racialized people. These these were systems that were not designed for people like us and our families. And although now you and I work in these kinds of health systems, they're certainly not meant to service our families and our loved ones in that way. And that's an important first step, because then it leads you down various tracks to think about. The research study that I talked about just shows like how we talk about palliative care needs to be different for different cultures and different people from different backgrounds. And in some cultures, in some languages, did you know that is not even a term, palliative care, that actually translates? So how do you actually talk about palliative care to someone from a culture who speaks a language where there actually isn't the term there? It also has to do with like how we assess pain and symptom management. For example, there's this is getting into the weeds a little bit, but certain kinds of pain syndromes that I was taught to diagnose, like nerve pain, for example, or neuropathic pain. I was taught that if the person I'm caring for uses certain words, like burning or shooting or lancinating or electric, this is an evidence of neuropathic pain. But my South Asian aunties, like in Brampton, Ontario, never said that when I was providing palliative care, and like that didn't mean they didn't have neuropathic pain, right? And so what we know is we underdiagnose, and therefore we undertreat certain kinds of pain in certain populations. Again, this has been shown to be true in Black North Americans and Hispanic Latino studies as well. And so, that has a lot to do with it. And then it also has to do with the way we design the facilities within which we support care, whether it's a hospice, whether it's a long-term care facility, whether it's assisted living communities, that they need to be not just culturally tolerant, they need to be culturally safe. And that means we have to actually train our health workers and our social care workers about the diversity of experiences that people have in hospice palliative care. And that ultimately means, being trauma informed in how we approach, the care that we provide. So I think we have a lot of work to do in hospice palliative care to make this beautiful thing that I know is an incredible thing, more accessible for South Asians and other racialized people across North America and around the world.
Yeah, I love that. Thank you. Yeah, and in the meantime, I think if individuals are empowered and can be advocates for their loved ones, while the systems aren't so conducive to the supportive care that we're seeking and hoping for, then yeah, advocating for what you and your loved one want, especially in the South here where we don't have so much diversity. So if there is a culture that we're not as familiar with, we turn to the loved ones to guide us as well. We do our part to educate, but kind of being that collaborative approach and patient and family centered is really important, like you spoke to. And those conflicts, you asked a question earlier, those are present across the board, different perspectives on death and how we support individuals to navigate all that with their families.
For sure. So maybe just one last question for you, Aditi, we can discuss, and then we'll open it up. I can see some amazing chatter in the chat box. I think we've talked a lot about the people we care for, who are always, our focus. But they're, one of the beautiful things about palliative care is we care for the caregiving unit, which is, family or informal caregivers, friends. We call them caregivers. Let's talk about them for a second. So when thinking about, our South Asian, community, how can caregivers, really improve communication to support their loved ones within the context of their healthcare teams? I have many, people who say to me, what should I ask my doctor the next time we see them, or the next time the home care nurse comes by, or when the home care coordinator calls, or whatever? What should I be saying so that my loved one gets the care they need, given that they, English is a second language, it's not, their culture per se? What advice do you have?
I think being okay with asking for help. I think that's a big one culturally. That what I've seen is that people think they have to, individuals that I know, and I don't know about the studies, what they show, but that collectively we feel that we have to do this alone. And I don't think that, I was just talking to my aunties yesterday, I was in Augusta, and they were saying that came from immigrating to the States. That's not how they did it and do it in India. Maybe now more so, nursing homes are popping up in India, and there's more care given at the end of life in the final days now in some cities. So I think just humility and acknowledging, asking for help when you need it. I would say that. And then acknowledging that you can't do it all alone. It takes a community. It takes a village. Just like it takes a village to raise children, it takes a village to support a loved one in their home.
Yeah, I just to add to that, those are some really great points. I would probably advise that loved ones really try to guide their family member or the person they're caregiving for to really see palliative care as part of the an approach to their care that will walk along with them along their journey and support them through any ups and downs that occur. If you trip, if you fall, they'll be there to pick you up. And, I think that that's a really important framing. I think it's also important, you mentioned this really quickly, Aditi, I just want to say it again, that palliative care can be offered and is offered in parallel with curative treatment. You can, get treatment for COPD or liver failure or cancer or, kidney failure at the same time as receiving palliative care. They literally can happen at the same time. And often people are shocked to hear that when you get good palliative care, you're more likely to be well enough to actually receive your treatment. So, the symptom management part of it is really huge. How many times have, I've been able to support the people I care for who are, having pain, and because I manage their pain well, they can go for their next radiation treatment, for example, just to give you an example of that. And I think those are two key pieces. And then the final one, particularly in when home and community care is connected to palliative care, we have a universal healthcare system, socialized healthcare in Canada. When you turn away palliative care, you're actually turning away something that your taxes already pay for. And I actually use that to my advantage. Sometimes I'm like, you've lived in this country for many years, your taxes paid for this, it's free for you at this point. Like, why would you say no? And that sometimes works, sometimes it doesn't. So I will say that it's the standard of care. And so when you kind of say that everyone gets this, normalize this, why would you turn this away, right? So I think those are three pieces of advice that I give folks. Yeah.
You all have that advantage. I hope. I don't know if that would ever happen here, but absolutely, good point.
To a degree.
I think that my dream early on, I think I did a talk in residency on integrating palliative care for heart failure patients early on. I did it in front of a group of cardiologists that didn't get it at the time, but the dream would be, once you're showing, anytime you have a chronic illness that you're dealing with, just get that extra layer of support to look at your whole being, right? Your whole unit, your whole family, all of it, symptoms. That alone, is worth it.
Thanks. Thank you, Aditi. And I think what we'll do is we'll hand it over to Andy, because I think there's been some really great questions, great conversation happening in the chat. Let's open it up.
Thank you both. I'm wondering if, Jagdeep, if you wanted to unmute yourself, if you wanted to ask your question. So Jagdeep, are you there? So Jagdeep had this question, about people coping with dementia. And there was some interesting back and forth about this conversation on dementia and palliative care and pain management. And I'm curious if you two want to address that.
Yeah, I'm going to just jump in to say this is probably the #1 question I get in settings like this, particularly with our South Asian communities, because I think a few things are happening. Our communities are aging. Illnesses like dementia are so common, and there is this, again, strong desire to keep our loved ones at home, which is a cultural trait and a cultural value across the South Asian diaspora. And I think this is a particularly difficult diagnosis among a set of other diagnoses to talk about, illnesses to talk about, because it's not always seen as a palliative care diagnosis. It's sometimes sold as a chronic illness, and particularly I'm thinking of people who work in geriatrics or our colleagues in long-term care. It's like dementia is often sold as this chronic disease that lasts over long periods of time. Well, the raw reality is it's a serious illness that's typically progressive, impacts quality of life, and so it is an illness that is of a palliative nature. And so it just depends whether people are willing to accept that now or later. It depends on the severity. There's different types of dementia, as you know, right? So I think it's probably important to see, no matter what stage or phase your loved one is at in dementia, no matter what subtype of dementia they have, that seeing an overall arching theme to approach the dementia is to see it as an approach to care that would benefit from a palliative approach to care from the start, which probably involves, yes, healthcare professionals who support a quality of life approach. And sometimes elder care healthcare teams do a really good job of the palliative approach to care. You don't necessarily need a palliative care doctor for that, for example, but it often, as time progresses, would require community care resources as well, including home and community care. And one of the things that I think South Asian families really struggle with is when people really deteriorate to a point where they might need a new disposition like long-term care. And there is a stigma in our communities about long-term care. And I'm not going to sit here and tell you should put your loved ones in long-term care, because I think we are in different places, and that might look different in different places. I also recognize that that's a different value system for different people. But I think there is this common thread that many people feel guilty even when they're thinking about putting their loved ones in long-term care. And that can be a very challenging situation when generations before us would have never done that, right? But people are also living longer, right? People are also living longer with multiple illnesses on board. You're also caregiving for not just one loved one now, you're caregiving for 2 or more. Sometimes I've been in homes where there were 4 elders in the home, and 6 offspring caring for those 4, and 10 in the multi-generational household. So things get complicated. It costs a lot of money. It can be very expensive. So I saw a few questions pop up about dementia. I just wanted to kind of connect the dots to a few concepts that I've seen. I hope this kind of helps to get some of those concepts out there.
Yeah, and I would say that the earlier you get palliative care involved, the more you get that extra support, symptom management needs and psychosocial needs and equipment needs and all that. And when their time comes to require hospice, it's a seamless transition generally. So, but all those things.
There's an interesting question here from Anup Barani. And Anup, if you're able to unmute, and actually I would encourage you all go into gallery view now. And if you can, we'd love to see you if you're able to take the video off. And if you can't, I understand that. Anup, do you want to ask your question?
Sure. So I had wanted to ask you all, because you all mentioned sort of having personal experiences within your own communities, which sound like fairly small communities that have grown, exponentially over the decades. And so, one piece that I am navigating as I transition from fellow to attending is helping family, friends, and people that I have grown into knowing in my own community here in New York and back home. And so that feeling of countertransference as you're caring for people. And so I'm just curious how you acknowledge and sort of navigate those feelings when you are shouldering some of those responsibilities.
Aditi, do you want to take that one?
Yeah, no, I think it's definitely a dance, I would say, to support individuals and really acknowledge the humanity in all of us, and then balance that with that professionalism and that guidance that we offer. So I think it's something that you'll always be aware of, and there's a tendency, to either two options: you get really rigid and boundaried, or you kind of give a little and connect with the human in them, is what I would say. But it's a dance.
I think that's really good advice. I would also add that I would take sort of a palliative approach to care for this. So I think it always starts with like, what are your goals of care? So sometimes, I hear about a scenario and I get the story and I'm like, well, I don't know if are they providing good care at that hospital? Like, that's not what I would do. And but what do we know? This is a story through three people. It's like broken telephone. And I try not to get into the specifics of the way the care is being provided, but rather what a person's goals of care are. So I'm supporting a friend. It's, hey friend, what, or for friend's mom, like what, friend, what would your mom's goals of care have been? What would your mom want in the scenario? Would your mom ever wanted to be hooked up to a feeding tube? Would, she ever wanted to be in an ICU? Like those kinds of things, and kind of bringing it back to the original goals of care from the very start of the conversation, that can make a really big difference, because then you're not kind of transferring your thoughts of like what you would want, but you're really zoning in on a person's situation and then kind of emanating the conversation from there. So I found that that's been helpful.
Yeah, and that idea of goals of care discussion, and if I don't know if you were trained in that, that was something I just learned in palliative care and hospice. It was all evidence-based practice. So this idea of listening and asking those questions was foreign to me. So goals of care is a good one.
An interesting question just popped up from Shweta. Do you want to ask that yourself if you want to unmute?
Sure. Thank you, Nahid and Aditi, for sharing. Didn't really have a question, but as a caregiver and also a holistic health practitioner, as an Ayurvedic practitioner, I death doulaed my brother a few years ago, and my mom is end of life now. And what I often find, and help friends as parents transition too, and I'm in awe how, because their upbringing culturally and everything is so embedded in religion or spirituality. There could be the dogma, right? And then there's the spirituality part. But regardless, whatever the principles and tenets are, I don't see that, at least in the Western palliative care world, of really connecting it to the soul journey. So it becomes a lot about growth, which is of course important, but then understanding and the approach to it and bringing what they've been marinating in for so many decades, right? And these principles, and really connecting it. And I know I do that with my mom, and she's still in denial and she's still afraid of death, no doubt. But that little baby steps I take on a pretty much daily basis in subtle ways or overt ways, I think helps her journey in different ways. So unfortunately, I came on late on the call, but I just wanted to ask if that's something you guys have seen as practices or models out there that kind of really focus a bit on that too.
Just to clarify, thank you for sharing all that. You're saying the spirit element, like really
yeah, because a lot of the older generations, right, like they're embedded in the Bhagavad Gita, let's say, or whatever religion is, and that the essence of that is so embedded on living the fullest life. Mm-hmm. But at a practical level, that doesn't transpire, or that doesn't get understood. At least that's what I find in my own mom and friends as parents. And so I kind of use that as reference points in these type of discussions of how we can live our fullest life, because they intellectually know that death is the only guarantee, right, that there is. But how are we going to proceed to that journey or that destination can be very joyful and a very fulfilling journey in different ways. Yeah.
Yeah, this idea of meeting people where they are, is a big one for me. And however you can approach it from whatever angle, to tap into that wisdom. And it may take 200 times to bring up the Bhagavad Gita and the wisdom of the teachings. And then one day or at her, or not, she may or may never accept it till her last breath. But yeah, I think that's a beautiful approach.
I also really appreciate this, Shweta. Thank you for sharing your wisdom with us. I'm so in admiration of this part of palliative care, and it's the mystic part that like really draws me to it. Like, not that I know enough about it or that much at all, but what I will say is that and there were some comments in the chat just to say that sometimes the dying process can be a beautiful thing. It's part of the human experience too. And sometimes our stigmatization of death in society and the death phobicness that we've talked so much about takes away from that, and I think birth gets this platform is this beautiful thing in the birthing process, but it can be that way. And when many of the South Asian caregivers who cared at home for their loved ones for months and years as their loved ones changed and deteriorated and eventually passed away, found that process very beautiful and very satisfying, and allowed them to move on in life. And so let's not stigmatize the death and dying process, and let's pay attention to some of these parts of spirituality that are so important. And I think palliative care can help with that, because it allows people to be symptom-free, pain-free, feel supported, so they can be still and be as well as one can be in that situation to go through it. I think it totally connects for sure.
And I think to prepare for death and to support people, we have to use the word and we have to talk about it, right? So yeah, all of it's important.
And
Sarmita had a follow-up question.
Sarmita?
Thank you. I'm so sorry, I didn't hear it. First of all, I want to thank Reimagine and both Dr. Dasani and Dr. Sethi for speaking excellent conversation. And thank you so much for taking the time to explain so much detail and make us feel at home with this conversation. I grew up in Canada. I've been living in the US for more than 32 years. I just lost my father in Halifax, Nova Scotia. He waited for me. I got back and he did wait for me. When I entered the room, I remember how my brother and my mom were just paralyzed. They didn't know what to do, how to be. And I don't know if with a background with my own healthcare provision and just my own spiritual journey, I just said, we need music. I think Howard just mentioned something about kirtan. I said, if our father is going to transition, then we have to give him some opportunity to transition beautifully on this journey and give him a lot of support. And one of the things, the chaplain came in the next morning. I got to spend his last 17 hours with him. I'm so grateful. And it was very sacred. I must tell you. Not everyone can be prepared for this. I wasn't, but I think my brother and my mom were even less so. But what I did know is to be present and to provide an environment of support for my father as he transitioned. One of the most helpful things was the chaplain and the palliative nurse the next morning before my father passed and after he died. They were amazing. They were not of South Asian descent, but they were extremely knowledgeable across the board as to how to help us with this transition. And even the chaplain prayed with us and gave a very universal prayer that was very powerful. He also said that the last sense to leave the human physicality is the sense of hearing. So we were fortunate to be able to be present, speaking with my father and playing those beautiful kirtans and the chanting and so on. But my ultimate question is, in our communities, how is it that our palliative care staff, knowledgeable people like our chaplains and maybe palliative care nurses, how can they speak to our communities so that we can prepare for the most inevitable thing, which is death, to help us work our way through it, to understand it can be a sacred process, and to take away maybe some of the, stigmas and fear that often surrounds that. Is that something that's being done now? And if not, then how do we help for that to occur, because the resources are in place, and I'm ever so grateful for those resources. Thank you.
Yeah, thanks, Sarmita. I really appreciate that. I'm just going to answer really bluntly to say that actually, our systems are not doing a great job of meeting the needs of racialized people in North America, particularly when it comes to palliative care. And I'm going to go as far as to say that this is a manifestation of not race, but racism. This is a manifestation of systemic racism within our healthcare systems. And I think that the fact that we're having this conversation is a manifestation of that it requires us to have a table talk about this topic. And so I think, you've hit on some of the really huge points that we're not going to get anywhere unless, our systems are better equipped to have these kinds of conversations. I think one thing that's really important is representation. I always say that representation is not anti-racism. It's not going to reverse the effects or alleviate the effects of systemic racism, but it is important. Like, it was really nice when, my South Asian family see a South Asian doctor or a nurse, who kind of understands where they're coming from. It can be helpful. It's something. I also think, when we're using tools in Canada, we use the Edmonton Symptom Assessment Score, but you'd be hard pressed to, find that tool in, translated in multiple languages. That's surprising given how diverse Canada is. It's mostly just offered in English to coast to coast, and I think this is true in the United States as well. So the tools that we use to assess, also like how we are introducing home and community care. Like, we talked about it a few times as this layer of support, but not this like we're giving up and so we're throwing these resources at you kind of thing is really important. And then the last thing, and I've talked about it a few times, I think is just like there is this perception that certain people in our communities are more apt to send their loved ones to long-term care, whereas I think certain culturally diverse communities, it's part of the culture to keep your loved one at home, and if you don't do that, that's a failure. And so we have to do better. Just like I'm saying that that's what the culture often says, and we need to do better to support people who want to keep their loved ones at home, and to do better to support those cultures or the people from those cultures where they tried and it didn't work. We don't want them to feel like it's a failure either, right? So just hitting some of the key points that I think are really key. So for me, those are some of my thoughts there. Aditi, what do you think?
Yes, I mean, that's so beautiful. Thank you for sharing. In our country, and I've watched this happen, our hospice programs have become more privatized. And so what I found, so I think the last statistic I heard was 30% of our hospices are nonprofit now, 70% are for-profit entities. And what I found is that the education and going into communities and educating people and having these conversations isn't happening as much by those team members, because they're just trying to keep up with their census and the souls they're taking care of. And so this whole death positive movement, the work of Reimagine, the death doula movement, having extra layers of support, having people, because another thing people forget is that hospice is a team that comes in and then they leave. They come maybe once, a week, the nurse and then the social worker and chaplain, but you have 23 hours a day to be with your loved one. And so can we get creative with communities to support individuals more and to have these conversations? And I think that's happening,
Howard, you had a few questions, and I'm particularly interested in the last one that you had. Can you unmute and ask?
Sure. Well, one of the things that we find in working with South Asian communities is the reluctance to have strangers come into the home. So that's been a barrier, and we try and encourage them in saying that we're teaching you the skills you need to give effective care and make sure your loved one is comfortable. I've also tried speaking to congregations in gurudwaras, and I'm not sure it's really translated into people actually taking up hospice. I was wondering how to identify and reach the community leaders of our local South Asian communities to be able to provide education and allow them to help families that they are exposed to suggest hospice consultation or palliative care consultation. For us, we have palliative care frequently offered in hospitals, not so much on an outpatient basis. It's very hard to get reimbursement for people who do that. And hospice, though, has a more formalized structure, so it is easier to get support. I have to just chime in that I work in a for-profit hospice, but I do make a real effort to get out to the community, to nursing homes, and to try and find marginalized communities who could benefit from hospice. So I would say that I wouldn't necessarily say that a for-profit hospice is not a caring hospice.
No, absolutely. No, I didn't mean to suggest that. Thank you. Just that the funding I noticed in my experience was cut for the education piece when that transition happened. So thank you for doing your good
Yeah,
work.
to me, it's so important.
Yeah, I think oh, sorry, you just went on mute, Howard, with that last bit, sorry.
Oh, I'm sorry. And to educate doctors, I find actually our physicians are in tremendous need of education about hospice and palliative care.
Yeah. Yeah, so a lot, you're trying to unpack a lot, Howard, in your local community, and it's going to take time for sure. One of the things that has been helpful, particularly in the work that we've done in Ontario, in the Peel region, that has been helpful is finding internal champions who are part of those communities to kind of be the links and connections. So, I distinctly remember, speaking at, some of the gurudwaras and the temples, and even the mosques in the local communities. And it was our, emergency, room nurses who would be the link to that space, or a clerk who worked in one of the clinics, knew an imam, for example, and we would use different, people who knew that we were doing good work and could co-sign us, and provided warm introductions. And then we would meet with those spiritual and faith leaders and talk a bit about the work we're doing, and contextualize it within death and dying, with which most faiths tend to have a focus and support on. And we would offer a resource, and in many ways we would bring some version of what we call like sort of a death cafe into that space, but make it culturally safe. And so doing presentations and having discourse and seminars on advanced care planning in a culturally safe way with people from that community, led by their community or in conjunction with that community, to really create success. And we would evaluate, what does success look like? Is it 2 outreach events a year at that kind of setting, and saying, okay, 2 a year is great, and then you can slowly start to roll out services and build connections. And I really think that really worked in our community, and it allowed us to build connections. So I'd say internal champions, external champions, and leveraging that balance to really get in there and hone that message. But when you get in, have something to offer, right? So a workshop on advanced care planning and tailoring it to the needs of that community, talking about home care, providing an introduction to palliative care, going through a case study, connecting it to the faith somehow, just different ideas to make it work,
Hey, that's wonderful. Did you, may I ask, is that at a nonprofit, or is that through your palliative care practice? How are you finding the team and getting out there?
Yeah, so it's Canadian healthcare, right? So it's not for profit. So, this was part of our hospital-based palliative care program. There was at William Osler Health System at Brand Pacific Hospital, where I worked for several years. And, as part of the work that we were doing to do outreach in community, and there was always an element of that. And that's actually where the research study that I mentioned came from. So, there's always an element of building, palliative care is community driven. If you're not in community driving that conversation, you're not doing palliative care, you're doing something else. I don't know what that is, right? So that has to be part of it, right? Part and parcel.
That's great.
We have time maybe for one more question, but I did want to ask this one question. Reimagine has been leaning into this idea of what's known as post-traumatic growth, this idea that from the sources of our adversity, from the hard stuff of life, from mortality, and God knows we're seeing so much mortality these days, there may be opportunities for growth or transformation. And oftentimes there's a time when no growth or transformation may be necessary at all, that there's a time that we just want to sit with our grief. And I'm curious to learn from both of you. Aditi, you are like a triple threat with being a medical doctor, an end-of-life doula, a musician. For you, I'm curious about what role creativity has in transformation for all that hard stuff that you've seen within yourself or with others that you've worked with. And for Nahid, you are such a passionate healthcare justice advocate. And I'm curious for you if that struggle plays a role in pushing you towards more justice in this world.
Nahid, I'll let you answer that first, if you'd like.
Yeah, I think, first of all, thank you so much for these very insightful questions, Andy. I really appreciate it. I think for those who are new to the conversation around health justice, for me, it's the realization that we can achieve a world where not just people get the same things to be happy and healthy, not just people get what they need to be happy and healthy, but people get the resources they need so they can make their own decisions about when and how they want to be happy and healthy. And that's the difference between equality, equity, and justice. And I'm a firm believer that health and healthcare can be a medium through that. I mean, other domains of our world, like law and education, can do that too. But as someone who works in healthcare, I'm a firm believer that can happen. And what I've realized over the years, and it started with homeless health and palliative care, and it's kind of broadened out to conversations like this, is that a lot of people think this too. A lot of people in our communities are compassionate, are caring, believe in the collectivism. There's a lot of discussion nowadays about I have rights for, and it's probably, there's a lot of people out there who actually don't believe that. They believe that we should be talking about I have obligations for. So what are your obligations? What are my obligations? What are our community's obligations? And I think that, seeing my people struggle, and I mean that in the broadest of terms, whether, growing up in a poor suburb of Toronto, being South Asian, seeing South Asians struggle with palliative care, seeing people who are working poor, living in poverty struggle, it has channeled, a sense of frustration in me. But I believe that through compassion, through empathy, and through a drive towards justice, we can get there. And I hope that conversations like this are the seed or the nidus for a way to get there, and I'm a firm believer in that. It might sound hokey pokey to some, but yeah, it's very real. Yeah, thanks, Andy.
Thank you, Nahid. And Aditi, tell me about your experience with music, with art, with spirituality, and what role that has played in transformation and growth.
I think I spoke to this earlier, but this remembrance that we are these multidimensional, colorful beings, no matter what color, faith, gender, ethnicity, and we have our creative energies and our music and our art and our clothing and all these things that make us human, and bringing that into the space, these conversations around death and dying, and how we grieve and how we support one another in our grief, and how we live fully, and embrace all of it. I think that's, to me, essential, actually, to remember that death is not a medical event solely. There are medical implications to death, as we know, but it is social and relational, and I spoke to that earlier. And so kind of bringing that back into our conversation, I think, is where my passion lies. And I think music helps kind of embody and create this vibrational, experiential reality of the mystic, like of the mysticism and the reality of us being human. So
thank you again, both of you. This was such a wonderful experience. Folks, you'll all be getting a recording of this. Join us for our next table talk in June. I'll be sharing information about that as well. That's on June 15th. Special shout out to the Desai family who have joined us tonight. My colleague at Reimagine, Zubin Desai, and his parents are here. It's great that you're around. I wish everyone a beautiful evening. And let's give another round of applause for Aditi and Nahid. And I hope to see all of you soon at other Reimagine events. Good night, everybody.